Really great pleasure for me to be here in Bucharest, and especially in this hospital. When you get older, you are more interested with history, and especially Marie Curie. You may know that she is the only woman who got 2 Nobel Prizes, one for physics, one for chemistry. An amazing woman. So I have always great respect to amazing women. So it's also another pleasure to speak under her name and under picture. Right now, so I would like to share our experience in the treatment of spasticity in children. So with my team, we are dealing with this problem for more than 20 years. So I would like to share also our main philosophy in the treatment of this problem. So as the first, I think we may sharpen that a little bit. Okay, anyway, so the voluntary motion of a skeletal muscle is a balancing act between this facilitatory, inhibitory impulses coming from the cortex and also their combined interaction at the spinal cord level. So our whole tonus is controlled by these 3 important factors, and if some of them is missing, the balance is no more there. So the first philosophy is to find out which part is missing. And of course there are several etiologies for spasticity, but our major issue in pediatric patients is cerebral palsy. But again, stroke, multiple sclerosis, traumatic brain and spinal cord injury, anoxia, some neurodegenerative diseases are the cause of spasticity. And if you look to the epidemiological data, in Australia it's to every 1 to 2 births, but in our geographical region it's approximately 4 to every 1,000 births we have a CP kid. This number will not go down. Why? Because although perinatal care is developing a lot because of the IVH pregnancies and the high number of premature babies and the good quality of neonatology departments, we have these kids. They survive. That means the number of CP children will never drop, and 4 kids to every 1,000 births is a very high number, and 60% of them will develop definitely spastic cerebral palsy. This issue with spasticity is not new. If you have interest in history, as I mentioned, these are the ancient pictures from Egypt. You see spastic hemiparetic patient. This is another small statue in Bodrum Museum from 2,000 years before Christ. This is a dystonic spastic child. So 4,000 years ago they were spastic or dystonic children. So today I am going to concentrate on our experience with spastic hemiplegia, diplegia, and tetraplegia. Okay, everybody knows a mild spastic hemiparetic child walks on toe. One take-home message is we have to start with the rehab program very early. Here you see another child which was not treated in a proper way. The same spastic hemiplegic child. As you see, it has started here from the equinus spasticity, then the knee is affected, the hip is affected, the vertebral body is affected. So we have to start very early with the rehab programs. This is a typical spastic diplegic child, 4 years old, mentally normal, no problem with the upper extremities, but typical seizuring of the lower extremities. Typical patient. And then we have on the spectrum the spastic tetraplegic child, which has difficulty to control all her extremities. So I will show you also the post-operative videos of this patient. You see she is that much spastic so that she has swallowing difficulties, and due to that she is fed by gastrostomy. And one important issue, you see the pain. In the adolescent period, the pain is another issue that we have to deal with. And The last group, the tetraplegic plus with dystonia. 15 years old, mentally normal, spending all his life in this condition. This is not only for him, also for the family, for the mom, big problem. So this is the spectrum of the patients that we have to deal with. Why do we treat spasticity? Let the patient live like that. Okay, of course, they are not adults, they are kids, they are developing, they are getting taller. So they have the muscle shortening problem. If you have a specific spastic muscle groups, they don't grow as your normal muscles. With time, you will have contractures. Due to that, you have joint problems, subluxation, dislocations, and of course, pain. So we have to fight with all those things. So the treatment selection depends also on different criteria. The severity of the spasticity, the extent of development, child's age, mental status, geographical and psychological dependence. I will come to that issue. And of course, at least for my country, the insurance system, because people have different kind of insurances. And a very important issue is, when you deal with the family, what does patient and family want? Because you have a main goal. If you examine the patient, you come up with the idea, okay, we can create out of this child a level like that. But sometimes the expectations of family is that high. They want to, Olympic champion. So it's not possible. So, second point of our philosophy, how to treat. There are 3 important steps. The first one is the evaluation of the patient. I will come to that. And then, with the data that we get from the evaluation, the identification of the treatment goal for this particular patient. What is our upper limit with this material? I mean the patient. And then, third step, we have to plan the treatment for this particular patient in a wide range of time. We have to think that he is going to grow up taller and taller. So I start with the evaluation. Now, this is an important point. So after more than 20 years, I come up with the idea we have to examine the patient in a multidisciplinary fashion together. There should be the orthopedic people, pediatric neurology, neurosurgery, rehab people, physiotherapists, motion analysis. We evaluate the patient at the same time. So we have the orthopedic group here, we have the pediatric neurology, motion analysis, physiotherapist, everybody is together. Why? To avoid this. Because I'm sure that you have also patients like that in Romania with hip dislocation, severe pain or something like that. Or what happens if you just try to treat the patient by yourself? If you read the chart of this patient, written by my orthopedic colleagues, they said the patient is able to walk. If you read the chart, okay? Good. Now, this is our examination with such hip spasticity, etc. And this is how it works. Now, of course, it depends on your interpretation. You may announce this patient as a walking guy, but according to my criteria, unfortunately, this is not at least well walking condition. To avoid that, we have to work together. Anyway, I skip this. I think the computers, they have also their feelings. When you are in a hurry, they don't like to work very fast. Okay, so the first step was evaluation. Evaluation consists of 3 major issues. The clinical scoring, the radiological evaluation, and the motion analysis. Of course, all of you know what we mentioned with the routine Ashworth scale. Why do we need that? Or let's say spasm score pen. If we describe a patient, it's much easier to mention some numbers. If I say the patient has the PAN spasm score of 3, everybody knows that the patient has spontaneous spasms 1 to 10 per hour. It's clear. If I say Ashford 3, everybody knows, modified or whatever it is. So we have to speak with numbers so that we can compare the status of the patient during a long time. The second issue is with the radiological evaluation. Today I mentioned, before we start with treatment, we perform a cranial MR scan of all our patients. Why? Because in most of the, in cerebral palsy children, the damage is on the brain parenchyma. We should get enough information about our material. Look, this first MRI here, this is some periventricular locomalacia, but mild. So for this patient, you may have a high expectation. Here, we have on occipital region, bilateral, some parenchyma damage. Of course, the clinical picture will be much different, and on the third patient, practically there is no brain anymore. So they don't have the similar clinical pictures. And of course, we have to check the vertebral column and the hip issue before we start with the treatment. Coming to the gait analysis, as you all know, a routine gait has 8 different steps. So we have to evaluate the patient to come up with the major problems. And it's a kind of computer work. As you see on this image, actually there are different colors. So every movement of our lower extremities, there are different groups of muscle at work at the different steps of our gait. Now with the gait analysis, you can come up with exact information. Which groups are affected more? This will help for your treatment. This is how we do that. It's an 8-meter long platform. You have markers here on the foot of the patient, and then you have different photocells, like here on this picture. Okay, the photocells are all around the room, and then you can have a video like that at the end of the day. This is a spastic diplegic, so you can have an idea about each joint. You can, work on that hours and hours, and you can have a sagittal view to have an idea. And of course, this is just also visual information, but then you can work with the help of the computer for each joint. Hip flexion and extension. Okay, this is the normal range. So you can have an idea what has happened during these 8 phases of gait. At which part it is more affected, which side, and then your treatment may be more precise. We have a certain target, so you have to know where to shoot. So with the help of these 3, scores, radiological evaluation, motion analysis, we have different targets to shoot. What kind of surgeries? We can do some surgeries in the brain, okay, in the basal ganglia, or we can have the muscle as the target with botulinum toxin, or the sensory nerve fibers. If you have the target here, this is selective dorsal rizotomie. If you have your target at the dorsal root entry zone, this is DRES operation. If your target is here, this is intrathecal baclofen. And if your target is the motor nerve, the neurotomy. Depending on the information you get from the evaluation, you can come up with one of these as a solution, or with a couple of them. One important role is there is no law in the world saying that you are allowed to do only one operation on a spastic child. With time, we may come up with new ideas and with different surgical steps. But one philosophy is very important to make the issue good within our colleagues. What is the major problem? Spasticity. Okay? We are not able to change the damage in the brain. But of course, we are not allowed to attack the muscle, the tendons, the bones as a first step, because the major problem is the spasticity. We have to solve the issue with spasticity, and then in the long term, if there are some necessity for further treatment, then we have to ask for the help of our orthopedic colleagues. Never start at the age of 3, 4 with some of orthopedic procedures. This is our philosophy. So I will start very briefly to give some information for each approach. Of course, the easy one is the botulinum toxin, which is used everywhere in the world, even in the small countries of Africa. But my observation is it is overused. So when a limited number of muscles are involved, this is a good indication. When relaxing tone will produce a significant benefit to this particular patient, then of course, and of course before the onset of fixed muscle contractures. According to your target, you may pick up you may come up with certain points. We are doing multiple injections under general anesthesia with the help of the ultrasound. So you know exactly which muscle you are in, which amount of drug you are injecting. For example, this is a soleus injection. Sorry about the level, but you can see the tip of the injection. We enter through gastrocnemius into the soleus. You know exactly where you are. And then under the guidance, you just inject and you see how the drug practically distributes through the muscle. This is very important. And now, sorry about that. This is before and after. You see, I don't know what happened, but there is some discordance with the computer. But anyway, you have a good foot contact after botulinum injection. This was the main aim, and we have reached that. Next issue is peripheral neurotomy. This is a surgery on motor nerves when spasticity is localized to muscles or muscle groups innervated by a small number or just a single peripheral nerve. We always start with physical therapy. You tried botulinum toxin 3 times. If you don't have a good result, then peripheral neurotomy may be used. Again, the target is alpha motor nerve. Okay? Depending on your target, if you have a spastic foot, okay, your target is either tibial or soleus nerve. If you are dealing with spastic hip adductors, then obturator nerve. So it depends. I just want to show you one example, which is the simple one, the soleus neurotomy. So if you look here to the anatomy, this is the main tibial nerve. The first branch is lateral gastrocnemius. The second one is the soleus here. Okay, you have to find out. And before doing that, we are always performing a preoperative test of reversible nerve block. This is the good side of most of these procedures. We can test before doing the surgery the condition of the patient. If you inject a long-acting local anesthetic to your target nerve, you can see how the patient is going to look like after your surgery. For example, here, you just enter the muscles, hop. Okay, this is your target. You inject local anesthetic. You have chance of 3-4 hours. We do motion analysis. We observe the patient. The mother and father has also an idea what is going to happen after surgery. If everybody is satisfied, you can do the surgery. And this is how we do that. I don't know how many neurosurgeons are here, but just to give an impression. I mean, we have too much light, but anyway, so this is the main trunk here. This is the soleus nerve. What we are doing is just isolating the soleus nerve like that, and then we dissect it into its fibers. Then we stimulate each fiber, and we have a distal observation. If you get a strong response, okay, then we decide to cut only this fiber, and then we check whether the patient has still clonus or not. If the patient has still clonus, then we continue with the cutting of the fibers. Like that. You stimulate, you get a motor response. You stimulate the second one, the third one, like that. It's a simple surgery. Okay, just have a look. This is a 3 and 5 years old patient. We already tried 3 times with botulinum toxin, but the patient has still equinus spasticity. The knee is not that much affected, so it's the best time to do the surgery to have a good foot contact. You see, this is the normal side, I guess. Yes, there is no limitation in the range of motion. And if you check the other side, you see, that's it. Okay. Good candidate for soleus neurotomy. Just have a look. After 9 months, he has a good foot contact. And this is just a small surgery of 3 centimeters of incision. But the knee is no more under danger. Next step, selective posterior rizotomie. Here is our target, the sensory dorsal fibers. It is very interesting because this is a very old surgery actually, described by the big German neurosurgeon in 1913, Ottfried Förster. But because of the wars and etc., the surgery was not popular. Everybody has forgotten. And then at the end of the 70s, somebody came up with the idea, the repopularization of the surgery with better techniques. And I was also surprised when I find the paper of Ottfried Förster, 1913. Can you imagine? 100 years ago, he had these pictures. Documentation is very important. 100 years ago, this gentleman took pictures. On the left side, the preoperative spastic child, spastic diplegic, and on the right side, the adductor spasticity was resolved. So we have to show respect because we are doing exactly the same thing. So this is a little bit for neurosurgeons, how we do the surgery. This is on the operating table. There is a lumbar incision, and this is how we do the surgery. 2 surgeons, the physiotherapist is scrubbing, and the physiotherapist is in the surgical field, and this is the neurophysiology part, because we are doing EMG recordings during the surgery. So practically, the paravertebral muscles are dissected. We are using these kinds of saws to make the laminectomy. Okay, we cut the bone, and at the end of the surgery, we put everything back. And we are using this reciprocating saw for not losing bone dust. If you do that with Midas, you have a gap. So with this kind of saw, you have a good bone-to-bone contact after surgery. So skip this part. And this is how the patient looks like after we put all the electrodes. We have electrodes on gluteus maximus, the hamstrings, adductors, quadriceps, gastrocnemius, anterior tibialis, abductor brevis. So depending on the condition, and you have these electrodes like, you know, spaghetti all around, but this is important for the EMG recording. Next step, just having the cauda equina, all the nerve roots after opening the dura. And of course, here, this is S1 root. We have to separate the motor and sensory fibers. This is the motor fiber here. This is the sensory, because this is a surgery on the sensory roots. We are not cutting the motor roots. That means I'm not able to make the patient plegic. And of course, we always stimulate to be sure that we are manipulating the sensory root. This is how it looks like from outside. Okay, I'm stimulating S1 motor root. Everybody is sure this is motor, so we are separating the motor and we are going to deal with the other ones. On both sides, S2, S1, L5, L4, 3, 2. This is L5, for example. Anyway. And then, this is the motor. This is the sensory fiber. So we just put a cottonoid under the sensory fiber to be on the safe side. So the surgery will be on these fibers. So next step, under the microscope, we are separating this root into its rootlets. You see 4 of them. And then we stimulate each of them and we record EMG here. Routinely, when you stimulate a sensory fiber, you don't have a motor response like that. But here, you see, I am stimulating S1 and you see the adductor movement of both lower extremities. This is a pathological response. You have to cut this fiber to eliminate the spasticity. And of course, we are doing that like that. Also, the physiotherapist has his hands on the muscle because he is the one who knows the patient well. And we have another scoring system for the physiotherapy team. We got a scoring system of EMG, physiotherapy, and we have to compare this. This is how we manage that. So 2 neurosurgeons, 1 physiotherapist, we are stimulating and then we are observing the movement on the lower extremities. If you get no response, 0. If you get just some contractions on the stimulated nerve muscle groups, 1. If you get a response on the adjacent muscle group, grade 2. And then if you have response on the whole leg, 3. But if you get also response from the contralateral leg, this is grade 4. They are all pathologic nerve roots. And we have also electrodes on the upper extremities. And then we check the EMG. I'm not going into detail, but this is the system described by Dr. Park. He is the one who has done the highest number of rizotomies. Now, we are close to 1,000, but he has operated more than 5,000. Anyway, these are the EMG studies. Okay, in all patients, no more than half of dorsal L4 and S2 rootlets cut. Why? L4 is responsible for knee stability, S2 for urinary function. If the patient is toilet trained, never cut more than 50% of S2. And we immediately start with these double theraband techniques. The day of the surgery, we start with the rehabilitation. Okay, and then next day we start also with the balance issues. I'm not a physiotherapist, so I'm not going into detail, but patient selection. Who is the best candidate for rhizotomy? There should be no evidence of dystonia or rigidity, minimal prior orthopedic intervention, acceptable head control, and best age is between 3 to 6. Okay, let's have some patients. This is an 8-year-old boy, already late. He was treated in one of the best rehab centers in Turkey, but you can observe the limitation of adductor spasticity and in the lower part, bilateral dorsal flexion spasticity. He is able to crawl on the dorsal surface of the foot. He is able to use the walker, but look, okay, 1, 2, 3, 4, 5, 6 seconds. Okay, he is able to stand. This patient has 0 chance to walk in the future. So don't fool yourself. He is trained very well, but the treatment has stuck somewhere. The family is very happy. 5 seconds he is able to stand up, but you cannot, walk with that. And of course, he will be worse in the future. Why? Because he is going to get taller and taller. So, although it was a little bit late, we proceeded with the rhizotomy. This is 2 years later, the same child. You see, he is already taller. So he is able to move independently both sides. Look, there is no adductor spasticity anymore. Therefore, he should be able to walk. Okay. Of course, this is not a wonderful posture, but he is able to walk. He is able to go to the school. He is able to walk with his friends. The quality of life has increased dramatically. And if you look closer, he still has some foot problems on one side. So you can proceed with botulinum toxin. Okay? Or neurotomy. Let's see another patient. She is worse, but she is 4 years of age. Age is very important. Look, she has even problems with balance, and she has also difficulties, I don't remember, I think it was right, also in the upper extremity. She is not able to use the walker, typical seizuring, etc. If you think you continue with your rehab program with this child, again, the chance of being ambulatory is very low. So we have to push the patient with solving of the spasticity issue. We have to help to our rehab people. This is 1 year later, the same girl. As I said, on one side, upper extremity is also difficult. Again, look on the left side, she still has problem, and we proceeded also with neurotomy in this patient. But she has good trunk control, she is able to walk. Let's see another patient. 3 years old, tetraspastic, but also trunk hypotonia problem. I mean, typical, scissoring, tall walking, the same scenario. Okay, like a ballet, that's it. If we force only with rehab, without getting off the spasticity, this will be waste of time. 9 months later, and he is trying to walk on the sand, which is more difficult. And the first steps are always difficult for them, but he is able to walk independently. Look, he is able to grab this small thing from the floor, and he is sharing something with his friends. This is very, very, very important. Otherwise, they will keep their house. Of course, all surgeries, they have its complications, and with rhizotomy, the major issue is the intraoperative complications. So your anesthesiologist should be very much familiar with this surgery, because they may develop bronchospasm and aspiration pneumonia intraoperatively. Why? Since we are doing EMG recordings, we are not using the muscle relaxation. And they are mostly premature babies with the history of reflux, etc. So the anesthesiologist should be very careful. And I mentioned this morning the problem with hypotonia, the immediate postoperative problem. This was because of the fact that we practically missed the issue of weakness of the muscles. Right now we have a preoperative program. If we decide to operate a child with the indication of rhizotomy, we gave them a program of 3 months for strengthening of the muscles, so that we have good quality of strength after surgery, after removal of the spasticity. Okay, this was the 2008 results. I skip. If you check the literature, there is only one meta-analysis which compares the results between physiotherapy alone, rhizotomy plus physiotherapy. This is very old study, 1998, but this is this single meta-analysis which significantly has demonstrated that rhizotomy plus rehab program is much favorable. And this is also a very nice study from 2001, already 10 years ago, from Paul Steinbock from Vancouver, which has demonstrated that there is a very strong evidence that rhizotomy decreases lower limb spasticity and increase range of motion, and it also improves motor function, in particularly gross motor function assessment. Practically, what are the advantages of rhizotomy? Significantly decreased spasticity in the lower extremities, improved range of motion, improved gait. This advantage, it's an ablative procedure, long surgery, 3.5 hours, and you need a rehabilitation program after surgery. Coming to another topic, of course, not all patients are lucky like that. There are very severe patients with spasticity and old patients like him. He is 16 years of age, mentally normal, and this is his condition. Severe tetraspastic with opustatonis posture, scissoring, etc. And so in this particular patient, of course, the patient has no chance for ambulation. Just to relax the patient, you can perform pallidotomy, which is a stereotactic surgery. You put a small needle in globus pallidus and you practically, this is not a scientific word, but you burn this nucleus, okay? Then you have a patient like that. 2 days later after surgery, 2 days later, okay, he is relaxed. He has no pain. The mother is very lucky because she is able to care. She is able to change the diaper. Otherwise, she's not able to open the legs of the patient. And the most important issue is the child is happy. He has started to laugh. So this is what I have mentioned. For each patient, we have a certain goal, and we have to work for this specific goal. And there is no equal two patients on the world. They have all minor differences. And another issue that I have mentioned is the intrathecal baclofen treatment. So it's a GABA-B agonist, and it acts at the spinal cord level. So all of you are familiar with oral usage of baclofen. If you even use the highest dosage in kids, 60 milligrams, you have a subarachnoidal space concentration of micrograms. I mean, if you use an elephant dose for a kid, you will have a very low concentration in the subarachnoidal space. So, because of that, people have developed a pump which looks like that. For patients older than 4 or 5 years and the body weight at least 15 kilograms, you can use that. What we are starting with is a test dose. Before we do the surgery, we make an injection in the lumbar subarachnoidal space, and we inject 50 micrograms of baclofen, and we are able to observe, at least for 4 or 5 hours, how the patient is going to look like after surgery. So this is the test dose. And during surgery, we implant the pump somewhere here. There's a tube which goes through the lumbar area upwards. And the most important issue is the localization of the tip of this catheter. What is going to happen? We put the drug into the pump. The pump is going to work as we order him with our computer, but the drug is going out of the tip of the catheter. So the localization of the tip is very important. Where is our target? Are we targeting thoracal 8 or cervical 7? So we have to put the catheter at that point. There are some, of course, complications with the pumps because you are implanting a foreign body. That means you may have CSF collection, CSF fistula, but all these complications are approximately at 3%. And the late complications are either infection or catheter kinking. So these are our early results. We have just one injection. Now, coming to the point of advantages and disadvantages, and I guess it's similar here in Romania as in Turkey. So it's very highly effective in reducing spasticity, more legs than arms. The global function is often improved. You can titrate the dose, and it's a non-destructive procedure. So you don't cut a nerve or spinal cord, something like that. But disadvantage, the cost of the pump. In Turkey, it's $15,000, and not all insurances cover the expense of the pump. Another issue is the implantation and the refills. So the patient has to come every 5 or 6 months to the hospital so that we can fill the pump with the baclofen. And of course, there may be some system and drug complications. This is how we fill the pump. Through the filter, you inject into the pump like you put gasoline in your car. Just have some patience. 14 years old patient, severe head injury, it's a car accident. She was 20 days in the ICU, etc. Tetraspastic, but she has a good head control and the mental status is very good. So this patient has chance to walk. Although she doesn't look like that right now. Good head and body control, mentally good, and she had some shearing injuries, so diffuse axonal injury. Okay. 1 year later, 85 micrograms of baclofen. Of course, she's walking in a robotic fashion, but she's able to walk, she's able to go to the school, and she is able to go upstairs. Not all the schools in Istanbul have the chance for handicapped children, so you have to climb yourself. So she's able to go 2 levels up, and also with some support she's able to step down and go downstairs. The most difficult thing for a spastic child is walking downstairs. Another example for you. This is an 8 years old tetraspastic child that I already have presented to you. This is like a Hollywood movie. She was playing around the swimming pool. She saw 2 cables. She held the cables, electrical shock. She jumped into the swimming pool with the cables in the hand, cardiac arrest, but there was a good-looking doctor with some resuscitation, etc. And this is when she comes to our institution after 1 month of the injury. Okay. We discussed hours and hours in institution. Should we go further with rehab or immediate surgery? So I was for the surgery. I voted for the surgery. But anyway, because if you continue with routine rehab, because of the spasticity, the physiotherapist will spend his whole time for just relaxation work, okay, with stretching, etc. But if we relax the patient, he will use his whole time for active work, and the patient will improve much faster. So we decided to implant a pump. But just observe, just within a month, you see the range of motion is that much limited. It goes so fast. And just 9 months later, this is her, she is 95 micrograms. Of course, she's a girl, she looks all ready to mirror and, you know. If we have waited with rehab, we will never been able to get a condition like that. She is a little bit slow, but look to the fine motoric. And also to the thumb, so you will see I can proceed a little bit faster. Okay, there is nothing wrong. She is able to write right now, and look, without any support she is able to go downstairs. So in such a condition, to help the rehabilitation group, we have to solve the spasticity very fast, so that you have a very good material in your hand. And just some couple words with the new issue of deep brain stimulation. Okay, this is a stimulator like that you implant somewhere here under the mammillary issue, and then you put the tip of your catheter either in substantia, rigra, thalamus, GPI, wherever your target is. And of course, it is performed with the help of a stereotactic system. This is my colleague, Professor Peker. He is responsible for deep brain stimulation implantation because he is the chief of stereotactic unit. So they are doing microelectrode recordings. They put the electrode, let's say, into the thalamus, and they are just recording from each cell. And this is the pre-op and the post-op, the bilateral implantation. And let's have a patient. This is a secondary dystonia patient, Hallervorden-Spatz disease. So you see the tongue is moving very difficult in her mouth. She's just speaking Turkish. Even I cannot understand what she is trying to say. And this is how she walks. And after a couple steps, we had a similar patient today. Not exactly the same, but you say, okay, she stops. And we just implanted the DBAs. Now she can speak much faster, and I can understand what she's saying. And also, her gait has improved dramatically. So you will see that. say here. She's able to turn very fast. Okay, for secondary dystonia, deep brain stimulation may be also very helpful, but we have the limited numbers of patients. Now, making the summary, an algorithm for spasticity management, we have to start with physical management. You can use medical. The quadriplegics, if they are mild, rhizotomy, otherwise ITB, palidotomy, DBS. The spastic diplegic one, our first choice is selective dorsal rhizotomy. The hemiplegic, botulinum, neurotomy, ITB, orthopedics. I put these orthopedics because in each patient, we are following these patients together, and when it's necessary, if they develop contractures, of course, it is the job of our orthopedic colleagues. Summary, for the treatment of spasticity, a rigid treatment protocol cannot be given. Each patient must be comprehensively evaluated and treatment recommendations made based on the individual's unique needs. Several types of procedures can be combined in one patient. Every neurosurgeon will choose his own way according to his experience, but bearing in mind our goal, increase the comfort, prevent the limb deformities, and the improvement of function. And I have to thank all the members of Spasticity Treatment Study Group, and thanks a lot for your attention.
Astăzi înțeleg că 21 de copii, Ana zi bine, da? 21 de copii au fost văzuți de echipa de la Acibadem și vreau să mulțumesc foarte mult domnului doctor Cârstoveanu. Noi am vorbit la telefon, nu? Da? Vă mulțumesc tare mult pentru sprijin și vă mulțumesc, doamna Pădure și dumneavoastră, pentru că dacă n-am fi avut la dispoziție centrul dumneavoastră de recuperare, practic n-am fi putut să punem în practică. Mulțumesc tare mult! Dumneavoastră îmi spuneați că centrul e autonom din 2006, când pe structura secției de recuperare a spitalului s-a născut Centrul Național de Recuperare Neuropsihomotorie, unde au avut astăzi loc consultațiile. 21 de copii au fost văzuți, evaluați. Există șansa pentru un copil, pentru o familie, să aibă o viață mai bună, pentru că operația va avea loc la Acibadem. Eu aș vrea să știu dacă există în sală mămica lui Denis Ștefan Legradi. Da. Dumneavoastră sunteți? Puteți să veniți până aici cu piticul sau e prea greu? Da? Puteți? Veniți puțin lângă noi. Diagnosticul este paralizie cerebrală și necesită rizotomie. Asta îl va ajuta, asta îl va ajuta nu aici lângă noi, din mediul îl va ajuta să meargă. Cred că prezentarea a fost destul de clară din partea domnului doctor și știți deja cam care poate fi viitorul lui. Asta e prezentarea, da, asta este. Câți ani și 5 ani să vă trăiască. Cum a fost astăzi ceea ce s-a întâmplat cu doctor? Cum a fost consultația? Cum ați simțit lucrurile? Stați așa ca să vă vadă toate. Nimic. Cum ați simțit dumneavoastră ziua de astăzi? Examinat. Ceea ce e important de știut pentru dumneavoastră este că domnul doctor și echipa întreagă de la Acibadem pot să vă dea o veste bună. Copilul dumneavoastră este cel care va fi operat acolo.